Thank you, Ahmad. I've been surrounded by H, Hamad, Hamada, Human, Halim, but welcome everyone. I'm really excited, looking forward to this debate. And this will give you guys a very good idea how difficult or easy or fun it was planning this conference. So without any further ado, I will have, so one thing, they each would have 15 minutes for their starting remarks, then 5 minutes for rebuttal, and then 10 minutes for closing remarks. So I will have Human start the debate.
Okay, Bismillahir Rahmanir Rahim, Alhamdulillahi wahda wa salatu wa salamu ala man la nabiyya ba'da. Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to this long-awaited, at least on my end, and Hamada, we've been trash talking each other for the past couple of months around this debate, so we're getting ready to kick off, inshallah. So I might start with simply saying that as a prefect, as a sort of a beginning introduction, that the question of is Islamic psychology ready for clinical practice, I think it might be answered in a very short way. And that is that Hamada himself has invited me to teach at the Hartford Seminary, which is how I originally got to really get an opportunity to be mentored with him, to teach the methods that I'm actually practicing in clinical practice. So perhaps suffice to say that Hamada on some level has some cognitive dissonance, and he believes that that we're pretty much ready for clinical practice. But let's kind of humor Hamada for a little while for this for the purposes of this debate, and let's also say that we have been co-chairs on this committee for the past couple of months, and maybe this is our cathartic way of being able to get out some of our tensions actually as well. So let's see where it takes us. But truth be told, all joking aside, we have great love and respect for each other. At least I can speak for myself in that regard. Maybe Hamada might be able to speak for himself, but the reality is that Hamada, I see him as a mentor, as a senior to me. He's really kind of helped shape a lot of my thinking and clinical practice and work, and he's held me accountable a lot. And he's been very critical of my work in a lot, which has been for me a very growth promoting opportunity. So, I'm maybe this is self-esteem preservation, that I'm the junior, admitting that I'm junior here, and secondly to say that whatever critique he's ready to offer, I'm willing to think critically about, inshallah, and hopefully be prepared to make me better for the future. So I'm going to go ahead and share my screen. So by the way, I don't know if that counts in my 15 minutes. That was just kind of like—
It does.
Oh, it does. Wow. Okay. See, this is also the push and pull between myself and Hamada, because he's very, as a psychologist, I'm a little bit more process oriented, more flexible. Hamada's, medical model, standardized, measures, keep things exact protocol and manualized. So, okay, let's kind of jump into a couple of points that I have to say. First off, let's take a look at this. When we ask the question of, is Islamic psychology ready for clinical practice? The question is, according to whom? If the answer is current practice, or the common consensus among clinicians or academics or the psychological community, let's say, then the answer is easy. Because any philosophy or promising explanatory model that describes the human psyche, pathology, health, and its treatment is deemed acceptable within the quote-unquote expert community. And if we go with that standard, then the answer is simple. It's yes, because if we can include narrative psychotherapy, existential psychotherapy, psychodynamic psychotherapies, which have very little kind of outcome studies or RCTs, then who's to say that Islamic psychology is any inferior to any of these notions, and that it should be held behind. But if we say, okay, then it's according to the medical model, and they're the gatekeepers of what's deemed acceptable within the scientific community, and they're the ones that kind of bear the arms. And here's sort of a comical image that I've produced of Hamada holding a weapon, right? And not really letting anybody who's not got any RCTs behind them to in through. Then the question is, you know, we're evaluating ourselves by the medical model, and we determine that RCTs are the only standard in which we can kind of get into the club, and it's acceptable to be to practice psychology. Now, but let's go with that for a little while. Let's humor Hamada, and he's got kind of a pose here. You know, like bring it on, right? You know, and this is, by the way, you notice that his goatee here is a little bit blacker than it is today. So perhaps some of our stressful conversations have given him some white hair over the years. But let's go with this sort of evidence-based, right? Evidence-based kind of idea and notions, and humor this and entertain this for a little while. And if that's the case, my answer is yes and no. Yes, for a couple of reasons, and I'll try to go through them rather quickly. One of them because, you know, Hamada's got a public health hat, right, that he wears. And underneath it, he's lost all his hair, right? And I too am losing my hair, by the way, but I choose to keep my hat on my head. But from a public health lens, right, we talk about behavioral healthcare disparities, right, and help-seeking behaviors. And we know that there is a huge demand for mental health services and huge numbers of people that are suffering. And when we have these sorts of big numbers that are suffering, then we need to step it up and expedite and come up with a you know, cautiously optimistic, right, as Fauci says around the COVID vaccine development, right, approach to expedite and to try to bring something to the table. And what we're finding is that Muslims are unlikely, you know, faithful Muslims, those that are more religiously observant, are more likely to seek out imams, for example. So it's not necessarily an ideal model, right, where we have imams who are not trained in mental health to deliver mental health services, or they may be largely absent and or psychologically traumatized by culturally insensitive psychotherapies, or at best culturally sensitive psychotherapies that may not necessarily take into consideration their faith and their background, okay? So our patients, and you know, Khalil Center has developed for a little while now, and we show that certainly this is the case, and the proliferation and the expansion of Khalil Center rather rapidly in the past 10 years is just evidence for that Muslims are kind of craving and you know, Islamically oriented psychotherapy. And then the other reason why is because Harold said so. I mean, the thing is, you know, Dr. Koenig was on the IP track a little bit earlier. And if we take a look at some of the evidence that's being produced and developed, there's certainly some promising indications for spiritually oriented psychotherapies. At least we can say that there's sufficient evidence on depression and anxiety that using a spiritually oriented or integrated psychotherapies are effective, are evidence-based. In fact, Koenig demonstrates through an RCT that holds for 12 weeks and then 3 months after, 12 weeks of intervention, that for anxiety and depression, at least the modification of CBT is at least as good and sometimes better for more religiously oriented patients to integrate spirituality. Now, I recognize that there's limited data for an exclusively spiritually oriented psychotherapy across different kinds, you know, without a modification of standardized protocols. like CBT, like manualized, like the manualized, intervention strategies that are out there. But we can at least say that there's preliminary evidence, right, for spiritually integrated or exclusively spiritually oriented psychotherapies that are outperforming control groups, or at least equivalent to alternative treatment, and gains are maintained. Now, the data set admittedly is small, okay? I will definitely acknowledge that, but it should not be discounted because many CBT didn't start that way. Many theories show promising results, and then they go into phase 2 and phase 3 trials, just like the vaccines, right? We start to pump in money and support and to see where we can take it. Now, despite the fact that RCT isn't there, let's just pause for a moment and look at what types of evidence does exist for spiritual concepts, right? So cognitive restructuring works according to CBT, right? Outcome RCTs show this. The integration of faith and religion as a positive religious coping and protective variable against psychological distress is well established in the literature. Meaning making is an integral part of mediating psychological distress. CBT operates on the very assumption of changing human belief. The therapeutic relationship is an integral part of psychotherapy. So we show that therapist matching is really important in enhancing psychotherapy. So when we have spiritual values matching up with spiritual orientation within the interpretive framework and meaning-making lens, we show that we have a pretty strong case for spiritually integrated psychotherapy. Seligman in his work in positive psychology is showing immense data to support the notion of optimism and its relationship to psychological well-being. Looking at gratitude research, looking at forgiveness and the psychological benefits of forgiveness, looking at the relationship between, the negative relationship between materialism and distress, the positive relationship. The increase in materialism increases distress. And we can say that in a spiritual psychology, we are trying to get immaterial and more metaphysical. Looking at giving back, generativity is proven to be associated with psychological well-being. Looking at religious engagement on a communal level and more involvement with religious communities demonstrates protective variables and salutary benefits to psychological health. So now what are we saying? I mean, let me add this. I mean, the neurobiology of mystical experiences have also been shown, that there's the activation of certain parts of the brain that reduces activity in the amygdala and the limbic system that we know is associated with distress. A more activation of the amygdala is associated with distress. We've shown that spiritual techniques in psychotherapy can have empirically demonstrated effects on brain functioning, similar or more powerful than even psychotropic medications, right? Long-term meditation demonstrates changes in the brain and a responsiveness to resistant depression, in fact. So we are saying that there is significant evidence. And now when we say a TIIP, so I take a TIIP, traditional Islamically integrated psychotherapeutic approach. What is TIIP? We can say there are two components, let's say. Number one, it's we are taking interventions that work, that are proven to work, right? Like all of the things that I mentioned, and what we are doing is adapting it for the Muslim population, adapting it and providing it within the spiritual framework of our patients. And that is, so we can say it's proven to work, we're using it. Okay, it's putting flavor on the medication, so to speak, right? And utilizing it within the spiritual faith traditions and adapting it and giving it to our patients. The other thing, and of course, you know, how do you define a theory is not necessarily the tools. Again, we're humoring the empirical evidence-based argument, because I would argue that, you know, these are tools and we need a broader, more metaphysical explanatory framework, but we'll put that aside for a moment, anticipating that Hamada's you know, not necessarily interested in things that we can't demonstrate through the data potentially. So let's stay data driven.
Oman, just a reminder, you have 1 more minute to go.
Okay, okay, no problem, inshallah. And so we're going to stay close to the data, utilize the data in the TIIP. But the other piece is that we are going to use exploratory Islamic interventions that I would argue are effective on the spirit at the very least. But let's put that aside for a moment to come back to the data argument, right? But it may have promising value as demonstrated in the psychological therapeutic kind of laboratory, so to speak. And what we are saying is that it may have promising value. We may not necessarily fully be there, right? But it's certainly aspirational. And I acknowledge before Hamada even needs to say the words that there's limitations and that we are getting there. And through even his own critique, we are taking that feedback, trying to go back to the drawing board and trying to see if it works. Now we show through our data that people come into Khalil Center with clinically significant scores on the BSI, and their latest assessments are subclinical.
I'm sorry, Hamad, I have to cut you off here.
Okay, give me 10 seconds.
Okay, 10 okay,
seconds.
Go ahead.
And
give him extra 10 seconds.
That's fine. You can give
Just
it to Hamada as well. And so now we have a 1-year data set, which Hamada is familiar with over 400 sessions and 107 patients. And yes, he's going to say that there's no control groups or comparison groups, but I acknowledge it and I can frame it as a pilot study, and we're getting there and we're starting the process. And so now I hand it off to Hamada to tear up my arguments that I've laid in front of you.
Thank you. Thank you. At least I'm almost convinced. Okay, Hamada. It's Tuesday.
Okay. بسم الله الرحمن الرحيم الصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. ربي اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. I'll make sure my dua is longer than Human's for this debate. Okay, so assalamu alaikum wa rahmatullah. First of all, I want to kind of also offer some context to this debate. We did this debate for a couple of reasons. One is to keep it fresh, and this is our first time doing a debate, and we want to do something different and make things more interesting. And so, you know, Human, as he said, I agree. We are close friends, and we just because we love. The other reason to do the debate is to keep the standards. You know, this is a discourse, and we want to make sure the discourse, we're raising discourse and keeping ourselves honest in terms of the science and the work that we're doing. And the third reason is that, you know, this is something, I know this is Human's life work, and I'm going to poke holes in it and undermine it. And I think we have to have a space where we feel comfortable kind of discussing and arguing and sometimes of what's the best model. And we want to kind of model that of how we can have healthy arguments and discussions about things that are very important to us. So without further ado, here is my argument, my opening statement. So here's the outline. My argument is very simple. I'm gonna keep it very simple. Here's what I'm arguing. That to be ready for clinical practice, you have to have level 1 evidence. In other words, we have to show empirically that what we're doing is efficacious, it works, that is proven to work, and that it's safe, that it's not gonna make things worse for the person. And so we have to have that standard with any intervention we offer. And that's important for anything we do with our clients. And in order to establish level 1 evidence has been met, we have to have multiple randomized controlled trials. And Human knows that, and that's why he is trying to undermine that. But we know that to have level 1 evidence in any intervention, that we have to have randomized controlled trials. And I want to argue, I think Human has already argued for me, that Islamic psychology doesn't have level 1 evidence yet. What I'm not arguing is that Islamic psychology is not effective. I think it's very, very possible, in fact probable, that it's very effective. Maybe it's even more effective than other interventions. But what I am arguing is that has not been shown yet, that has not been proven yet. And I'm not arguing that Islamic psychology does not help people, because again, it could very well help a lot of people. And inshallah, Khalil Center and others who are providing this service, hopefully they are helping people. But again, we're not at the place where we can say this is ready to be scaled up as a clinical practice. And that I'm not arguing that Muslims do not need culturally appropriate care. Of course they need culturally appropriate care. But we do need to be responsible and have keep the bar high and make sure that what we're doing meets standards according to science. And so just to review for people, how do we know that intervention works and how is it safe? Well, we don't just ask Harold if it works or not. Okay, it's not. That's the lowest level of evidence, is expert opinion. Case series and case reports, or even observational studies where we're looking at process metrics, is also a lower level. Really, to establish level 1 evidence, you have to have not just one, but multiple controlled trials that are specific to the intervention and specific to the conditions that you're treating. Now, in terms of the pipeline and how that looks in terms of proving a intervention works, it always starts with some small proof of concept studies in which you're developing your method, you're developing your intervention, you're formalizing it, you're making sure all the people who are using it are doing the same thing. And then you're tweaking it, you're adjusting it, you're changing it so that it can be better and better. And then after you've done a couple of these studies, you move on to case series and maybe case controls. Case control, you have a control group, you have a group that have not been exposed to the intervention. And control, if you see, is there a difference between those who got exposed to intervention and who are not? And this is what I'd argue, this is where we are. We're in between these two areas when it comes to Islamic psychology. And we're far from randomized controlled trials. You know, inshallah, I hope maybe another 5 or 10 years, Human will come back and show the clinical trials, and then we'll talk about the methods and the outcomes at that time. Now, of course, it's easy to undermine me and say, get off your ivory tower, medical doctor, what you just want to throw pills at the problem. Well, don't believe me, believe American Psychological Association. American Psychological Association, your own discipline, has the highest standards. Actually, they were decades ahead of the medical establishment in terms of establishing standards for quantitative methods. And so they have established guidelines of what is considered good evidence for good and best practices. And within those guidelines, it's the methods we've all learned in graduate school. Let's make sure we have good construct validity in our intervention. In other words, is our intervention actually helping? How do we know that it's the intervention that's helping? Maybe it's the therapist. We know that from the science, from the empirical studies, we know that there's plenty of evidence that independent of the therapeutic modality, that the therapeutic alliance with the therapist drives the outcomes even more than the therapeutic modality. So maybe it's not that the method, the theory and the method is working, but maybe people just like Human, and whether Human does CBT or psychodynamic therapy, it's the therapist that is driving the outcomes. But it's important to know. Otherwise, what's the point of getting all this training and getting master's degrees and PhDs in a method if it's really the therapist? It's perhaps more important in some cases just to make sure the therapist establishes alliance. But you don't know that unless you have the right study design. It might be with time. Maybe with time when people just get better. And again, you have to show that with a randomized controlled trial. That's the experimental model that establishes construct validity. Threats to construct validity is confounders. So again, if you, in the Islamic psychotherapy, you're also doing CBT, cognitive behavioral therapy, which one is actually working? Which one is actually helping the outcomes? Maybe it's the CBT that's helping the outcomes. Maybe it's something else that's helping the outcomes. Maybe something else in their life is helping the outcomes. For instance, many outcomes are actually going down these days because of Corona and some of the pressures that we're having politically and socially. And so if we didn't have control groups to compare and watch two groups over time, we'd be misled by the outcomes. External validity. Is the intervention applicable to different groups, and not just different groups, in our case, Muslims, but even different cultures. Are different people receptive to the same intervention? So how generalizable is it across cultures? Now, I think for the most part, most of the discussion, Islamic psychology has been used as a transdiagnostic intervention. In other words, for different types of conditions, but it's something that needs to be looked at. Does it work for anxiety the way it would work for depression, the way it would work for other conditions? That needs to be shown empirically. And then this is an important thing. Are the therapists doing the same thing? So if you have a study, including Human's, the work that Human is doing, are they all doing the same thing? Is the way people talking about forgiveness with one client the same way a therapist is talking about forgiveness with another client? How is that being accounted for? And I think Human jokes about manualization, but I think that's the way to standardize things and make sure what you're doing is consistent. So again, to establish clinical guidelines and something is a practice, you have to have level A. And again, this is the American Psychological Association standards. It's also the medical standard, but this is the standard. You have to be level 1 evidence to say that this is ready for clinical practice, that it's safe and efficacious. You have to have multiple randomized controlled trials, and everything else does not meet the cut for that. So I will cede my time to Human, and I will, because I'm more concise and to the point, and we can move on.
So here's the thing, Human. Is absence of evidence evidence of absence? So here's your rebuttal.
That's a really good point. Well, Hamada and I have both, I think, agreed between both of our presentations that lack of evidence does not mean no evidence. It means that we need to investigate more, right? And we need to look more. Now, I'll address one point real quick. When I meant to say Harold Koenig, ask Harold, I was not referring to his expert testimony, but in fact, his randomized control studies, right, that does demonstrate level 1, criteria, meet that criteria for readiness for clinical practice, at least on depression, anxiety with Muslim patients utilizing CBT. Now, obviously, Hamada could, poo-poo that very easily by saying that it's CBT and you're ultimately doing a cultural adaptation. But that's part of my point, is that I'm acknowledging that we are utilizing evidence-based protocols, right, that have been proven to work at the very least with our patients in an integrative capacity. Number 2, that spiritually integrated psychotherapy also has been demonstrated to have RCTs. However, the data is too small, and I don't think it meets the criteria of generalizability yet, and that's a weakness, and that's an acknowledgement. But it shows promising results that are maintained with low levels of patients, right, low numbers, in a generalist non-denominational approach, okay? So what I'm saying is that take these two combined, add on to it all of the different various facets of psychotherapy that we know as clinicians we get trained in. The consolidation of the therapeutic alliance, forgiveness, gratitude, optimism, all these things that are so central to a spiritually oriented approach are salient ingredients and features and demonstrated, proven interventions that are weaved in an integrative fashion. Now, is the sum, recipe that's put together, the protocol manualized? No. And that's also a question. And I want to, let me just share my slide for a moment here. There's, and I'm not necessarily making this argument, but I'm humoring. Let's humor this for a moment. That. Are we bound to RCTs? I think we have to look at the fact that postmodernist theories, psychology is very broad. And you said APA sets a standard. Yes, it does, but there's also great diversity in APA. For example, APA also, had a hand in the torture of Muslims through military psychology, right? And there was a consensus, or there was agreement. Our association did something that we didn't agree with, and we were all members of that we did Toba from it like years afterwards, right? But the field of psychology has great epistemic diversity, and I think we really need to think about this. We'd have to throw out a lot of psychology if that's what we're going to use as the sole standard. Now, even if we consider RCTs, let's take a look at the question of construct validity. This is a huge problem, and Hamada has to admit to this in psychology, and the medical model always questions whether psychology fits within the social sciences or within the hard sciences or within the sciences at all. And when we look at depression, anxiety down here, inter-rater reliability is not even a moderate effect that we're finding from clinicians to clinicians. We're having different conceptions of the very same diagnosis. So we have to admit that psychology itself does not carry the same type of effect. And we're dealing with, I'm arguing, that we're dealing with more than biology. The more biological we get, the easier to measure, the easier to have linear designs, and not to mention manualized interventions are limiting. People question that. Those who are process outcome, they say what? They say, we are clinicians, and maybe Hamada's largely researcher heavy, light on clinicians, clinical practice, right? I'm clinical practice, light on clinical trials. And I know that the vast majority of CBT people that I know do not practice manualized CBT. They weave in all sorts of things, and that's the critique. The critique is that it's not generalizable to real life practice. So they say this RCT may be limiting, or it may not be useful, as useful as we want. Certainly APA says it's a gold standard. Let's take a look at the APA report. The APA report does not say, as a correction, that it's the only standard for clinical practice. Rather, it says that it's the gold standard for clinical practice. It's very important nuance here. And we look at the empirical evidence practice that is admissible according to the APA report. We have things like process outcome studies, naturalistic studies, case studies, qualitative studies. And when we widen the pool of data outside of RCT, I think the case becomes almost closed for the fact that an Islamic psychology certainly can exist, and it needs to continue to demonstrate further evidence. Let's take a look at mindfulness. How did mindfulness scale up really quickly? Same phenomenon. We started soft, we introduced Buddhism, we demonstrated some effects, and now here we are. And Islamic psychology, I think, has much more promising potential given the richness of the Islamic intellectual heritage. The last point I'll make is, let's pause for a moment. We're Muslims here at the end of the day, right? Muslims and Mental Health Conference. So our Islam shapes our epistemology. That means that that true knowledge is also from the spiritual. So if the Prophet ﷺ said, use this dua, Bismillah alladhi la yudurru ma'a ismihi shay'un fil ardi wa la fis sama'i wa huwa as-sami'ul alim, and you will not be harmed by anything. When the Quran says it's shifa, right? When we are saying that, say this dua, Alhamdulillah alladhi afani mimma ibtalaka wa faddalani ala kathiran mimman khalaqa tafdila, that you will not go through the same trial that you've witnessed somebody else go through. There is no way you can measure that. It's beyond measure. It's beyond RCT. However, as Muslims in an Islamic psychology, we give assent to the fact that we do believe that scripture that is proven and established has benefit. And that's a true source of knowledge. And so we are not saying, you can take a look at spiritual therapies and say, spiritual therapy is only effective. Why? Because you can be an atheist. You don't even need to believe in the soul, right? The bottom one. They say, despite not positively affirming the soul, give me 30 seconds. This is my last point that I'm finishing with. Because there are spiritual therapies are simply cognitive, emotional therapies that we can have mechanisms for change that's measurable, okay? And you can be an atheist and show that data, and you have to accept it as a scientist. The other approach is to say that because they affect the soul, and that there's also salutary effects that we can demonstrate psychologically, but at very minimum, we also believe that it has positive effects on the spirit. Of course, there's got to be training in that and best practices, because people may actually do harm, and I agree with that. And so that's the part that we say definitely it's ready for practice. Finally, the no part is I acknowledge the limitations in data, but we have promising potential, and that's where I sort of rest my case.
Okay, so limiting, so lack of data and limited scope. So here's your rebuttal, Hamada.
Okay, so there's one clarification. You said you rest your case. Are you ceding your time for your closing arguments?
No.
Good try.
Okay,
That was a good try.
I also see that people are getting excited on the chat. I'm looking at you, Dr. Kerry York. So I'll take both of you guys on, no problem. Okay, so, and again, and in all seriousness, we purposely kept this short, or relatively short. We're trying to keep it relatively short, so we can open up for discussion with the group. So I'm ready for you, Kerry. So in terms of I'll put my slides in a second for the rebuttal. But in terms of RCDs, so I think we're confusing a couple of things. Number one is you can see that it's a gold standard. So we want to keep our interventions at the highest level. And that is the highest level of proving something is working and was safe. It's an experimental model. All those other methodologies, where it's narrative methods or qualitative methods or mixed methods, is to learn more about the intervention and learn more about our situation. It's not to establish clinical practice. Now, I look at psychology and mental health in general as a science, as an empirical science. And when we find something doesn't work, or quite frankly is dangerous, we leave it alone. Now there's a danger, and this is why I always include efficacy and safety. There's a danger. I mean, that's fine. We have different sources, epistemological sources of information, empirical, wahi, revelation, and rational. But what gets dangerous if somebody says, and you appeal to authority, this Islam says this, Islam says that, and this is what I'm going to prescribe you this, and read these surahs, and drink this, and you don't know what's happening, and if you don't show it works or doesn't work, you're at risk of endangering the person that you're trying to take care of. Okay, so let me go to my rebuttal slides. Okay, so not reasons for justifying Islamic psychology for clinical practice. Muslims want it. Just because Muslims want it doesn't mean that it's ready for clinical practice. That we're already doing it. I mean, so there's a whole set of ethical issues with doing something that's still being worked out. And so you can kind of sprinkle it in or integrate it, or if you're trying to formalize or prove it's working, you can get an IRB and test it, and test people who are given standard care versus the experimental care. Muslim coming to us and happy with our service. That's the issue of access to care. And so you might be providing cultural competent care or culturally appropriate care, but it doesn't answer the question, is it efficacious and safe? Harold says so. We already talked about appeal to authority and flavor on medication. This is actually an interesting question, is if you're integrating all these different pieces that have already been proven, like cognitive restructuring or whatever those pieces are, then what is Islamic psychology? And it's important to distinguish yourself and establish exactly what is the technique that you're arguing. I'm going to skip this slide and just say that the evidence that Human showed for spiritually oriented psychotherapy is not Islamic psychology. It's spiritually oriented therapy. And so you're extrapolating something that's not specific to your method. So I'll leave the closing remarks for later. How much time do I have, Farha?
You have a couple of minutes more.
I'll cede my time.
Before, because you ceded your time before, but if you're done.
I'll cede my time again. I'll wait for Kerry to attack me once you open it up.
Okay, so Human, 5 minutes for your closing remarks, please, because I can also see the chat room is bulged and
I don't have much
questions. So why not open it up for discussion? So why don't you have 5 minutes for closing argument?
I agree. You know, in conclusion, you know, I'm fully on board with being critical of Islamic psychology. So this is, my argument is not to say that we shouldn't be critical, or that despite the fact that let me say this, RCTs are necessary. However, I don't think they're sufficient, right? And I think that RCTs are very limiting. And I question the notion that in psychology, that's the only epistemological kind of demonstrable evidence that we need. Now, APA also backs that. So I challenge the notion where Hamada is saying that it's, APA is saying that it is the only, it is the only standard. It is a gold standard once again. But process outcome studies, for example, are, by the proponents of them, challenged to generalize better to real life settings. And they are scientists that actually do critique the RCT and refuse to take an RCT approach because of their philosophy and psychology, right? And so what I'm saying is, let us look at the big picture is what I'm trying to say. And I'm not saying that RCTs are not necessary. I'm saying we need to have them so that we can silence the critics at the very least, right? And I also agree with the do no harm principle because of the fact that we're talking, psychology is not only a science here, and Islamic psychology is not only a science, it's also a faith tradition. It's the spirituality piece. And Hamada is right. People will use Quran and Sunnah in the wrong place. And that's why competencies and trainings need to be established for both, because I am critical of that, you know, psychologist who's never gone through a formal seminary course even, and then come to the table and speak in the name of God, right? To say that this is what this is what Islam has to say to you about your tradition, in the same way that I would be critical of clergymen coming and say, I speak in the name of God to extrapolate something that God is not saying about that person's case-specific phenomenon, something he knows nothing about because of his lack of training and anxiety and religious, or rather mental health or mental health standards. So I agree, we got to raise the bar. And I accept the challenge that Hamada is giving me. And I hope that 5 years later, he will be critiquing me on the RCT that we've established and whether it does have generalizability or whether it's methodologically valid or reliable or not.
Thank you. So Hamada, 5 minutes, please.
No problem.
You have to take on the whole chat room after that.
Hamada, you kind of put yourself in a corner, you know, like you're taking on Islamic psychology, you're arousing a lot of...
Okay, so this is what I argued. So Humayun has conceded that RCTs is a gold standard. It is one of many methods, and doesn't end in the RCT. I acknowledge that. I also acknowledge that RCT is is for a specific group, is idealized, it's not generalizable. But we have other methods. We have implementation research, where we have phase 4 RCTs. In other words, how does this intervention that's been proven in an idealized set of conditions, how does this generalize to the real world, to the natural setting? So we're using this terminology imprecisely, because these different methods all inform how can we make people better. In terms of the gold standard to show that something is efficacious and safe is the RCT, and to see that it's generalizable, that's implementation science. Okay, so I think it's important that we use, you know, that we understand that, you know, with in RCT we exclude this group, we only include this group. They're in a very kind of artificial environment, and then in real life people don't actually use the exact manual. Well, that's what implementation science is for. That how does this intervention actually play out in real life, real world science? So there are methods for that. But before getting to that place, before doing the real world science, implementation science, you need to have the RCTs that establish empirically that this intervention works more than the comparison group. I will end with a quote but by an esteemed colleague. It said Islamic psychology. I'm asking you to vote for myself. Okay, Islamic psychology requires further investigation. It's clearly an impoverished domain, and that quote was from nobody except Human and his research group. So we still have a lot of work to do. Okay, I think Human can concede defeat. You want to concede? You don't have to. You can save them the vote.